We are good to go.
Good evening, everyone. It gives me immense pleasure to welcome everyone in today's ACP Case Files, a John Tucker Award winning series. And I extend a very warm welcome and gratitude to our Governor, ACP India Chapter, Dr. Anuj Maheshwari Sir, Dr. Amit Gupta, Advisory Council Member, ACP India Chapter, and our most esteemed experts who have won accolades in their respective fields and who took out their prestigious time for the session of ACP Case Files. Before starting with the sessions, let me take this opportunity to welcome and request our Governor, ACP India Chapter, Dr. Anuj Maheshwari Sir, to say a few words.
Thank you, Dr. Preeti. Hope I'm audible.
Yes, sir, you're audible.
So I welcome all the delegates and all the attendees, especially all the members of the India chapter, as well as from out of the countries or across the border, those who are willing and those who are going to attend today's program. As we all know that early career physicians are facing a lot of challenges in their practice. So just to handle their challenges, just to help them handling their challenges, not only on the front of management of the patient, but also on their personal front. We have designed this program, which is known as the ECP case file, Early Career Physician Case File. And in this program, we always try to put the topics which may be useful for the early career physician. And we request senior professors and senior faculties of the medical colleges and institutes to tell their experiences to our attendees through the cases, challenging cases, what they have tried to manage in their day-to-day practice. And probably they may be really useful for their practice also. Apart from that, second part, we also keep reserved for the personal front of early career physician. And in the same way, today we shall be having this program, which has been popular also, the award winning program of ACP India chapter. So looking forward for another very inspiring and useful program under the new leadership of our new ACP in charge, Dr. Preeti Singh Lohar. And I am very happy that Amit is also there to encourage uh, early career physicians team. And Amit, you will also be there. And I believe that you will be giving the closing remark. But before that, if you want to say something, you are most welcome.
Thank you, sir. You have always inspired this program, and now it is running into its third year, and it is good to see new panelists. And every time we are adding national faculties from all across the India. And this time again, Dr. Preeti has set up a very good case as well as very good topic for the early career physician. So I wish Dr. Preeti all the best. And Dr. Preeti, you can proceed with the program.
Thank you, sir. Thank you, sir, for your constant support and guidance. Now, I would like to request Dr. Deepak Chaudhary, who is the moderator for today's session. Dr. Deepak Chaudhary is Assistant Professor, Department of General Medicine, AIIMS, Bathinda. He has special interest in infectious diseases, intensive care, rheumatology. He is a member of various professional bodies and a guide and evaluator for numerous postgraduate students. He has numerous publications and reviewer in many index journals. He has written one book and many chapters. I request Dr. Deepak Chaudhary to kindly take over.
Thank you, ma'am, for your kind words. A very good evening to all. First of all, I would like to thank Dr. Anuj Maheshwari, sir, Governor ACP, Dr. Amit Gupta, sir, Dr. Preeti Singh Dhot, ma'am, for giving me this opportunity to be here on this prestigious platform. Kindly accept my sincere gratitude for the same. So, starting with our first speaker, I will welcome Dr. Vishakha Jain, ma'am, Additional Professor and Head, Department of Internal Medicines, AIIMS, Bibinagar, Hyderabad. Ma'am has very certified course in evidence-based diabetic management, is a fellow of FEMA GMCH 2017, and is currently working as Deputy Medical Superintendent as Clinical Services in All India Institute of Medical Sciences, Bibinagar, Hyderabad. She is a member of Board of Studies, Data Meghe Institute of Medical Sciences, GRMC Swangi, and member of Board of Studies, All India Institute of AIIMS Bathinda. She is also the course advisor for Advanced Pediatric Nutrition course for the past 4 years. She has more than 60 scientific papers in peer-reviewed journal index national and international levels, with having 6 book chapters and editing 2 books. She has also authored many patient education material in venerable vernacular language for the patients. So today we will be unveiling the renal enigma of a multifaceted complex case. So over to Dr. Vishakha Jain, ma'am.
Thank you, Dr. Deepak, for your kind introduction. And at the outset, I would like to thank the organizers and my gratitude to Dr. Anuj Maheshwari, Dr. Amit Gupta, and Dr. Preeti for having invited me to this platform, renowned platform for presenting the rare case. So with all your due permission, should I start? Okay.
Yes, ma'am.
Yeah. So thank you. So today I'm going to take you through a very complex, multifaceted case which we recently encountered in our institute. And I hope that this case would be a good learning exercise, as rightly pointed out, for all the earlier career physicians. So the case was an 18-year-old young male who was apparently healthy and presented to our OPD with complaints of bilateral loin pain, fever, and vomiting since 2 weeks at the time of presentation. He had had 1 episode of painless hematuria in the past 1 week before presentation, which was frank red colored. There was history of frothy urine present since 1 week. There was no history of any puffiness, edema feet, or anasarca. There was no difficulty in voiding any dysuria or decreased urine output. There was no history suggestive of any infection, upper respiratory skin, any joint pain or rash. There were no similar complaints in the past, and the patient did not have any other comorbidities in the form of tuberculosis, diabetes, sickle cell disease, no history of renal calculus disease, or there is no history of any immunocompromised or suppressed state or being on any medications. Next slide, please. On examination, the patient was mildly tachycardic with a normotensive blood pressure, respiratory rate which was normal, mildly elevated temperature of 101 degree, but there was no pallor, icterus, no lymphadenopathy. There was minimal pedal edema, no rash, and had tenderness over bilateral flanks, but there was no other organomegaly or ascites, and other systemic examination was normal. Next slide, please. So after taking the history and clinical examination, there were 3 things that looked at us, which was the bilateral loin pain, fever, and hematuria. And to continue with this, we thought as our first provisional diagnosis as being acute pyelonephritis. Now, we were thinking about acute pyelonephritis in a patient who did not have any history or any risk factors suggestive of acute pyelonephritis, but though the syndrome fit clearly into acute pyelonephritis, but we had other differential diagnoses. Next. So our second diagnosis was rapidly progressive glomerulonephritis. Because the patient complained of hematuria, there was frothy urine. We also entertained a diagnosis of infection-related glomerulonephritis because of history of fever, hematuria, again frothy urine. Next. Renovascular diseases, though the patient did not have any comorbidities, but keeping it on the 4th. An autoimmune disease leading to any renal dysfunction. Next. A very rare syndrome of loin pain hematuria syndrome, only seen in cases of 0.012%. And next. And lastly, we had to entertain the diagnosis of tuberculosis of kidney. The patient had a presentation of about 2 weeks in a country which has a lot of tuberculosis presentations. So these were our provisional differential diagnosis after history and examination. Next slide, please. So after the initial investigations, we found that the patient had a TLC which was around 17,000, which had about approximately 78% of neutrophils and 13% of lymphocytes. The platelets were marginally reduced to 193. The other investigations in the CBC panel was normal, and the peripheral smear was normocytic, normochronic. On the CU examination, we found that the patient had complained of frothy urine, and we found a protein which was 3+, 1 to 2 RBCs, hardly any pus cells. And when we went ahead to do a urine protein 24-hour estimation, we found that the patient had a nephrotic range proteinuria with 16972 milligram per deciliter and a urine ACR of around 6069 milligram per grams. So this kind of gave us another clue that now we were dealing with something which was causing the patient a nephrotic range proteinuria. Next slide, please. We went ahead and did his other investigations. And when we did his renal panel, on the first day when the patient had presented to the medicine OPD, He showed a creatinine of 1.3. We had advised the patient admission. The patient came back for admission on 9th, and then it was found that his creatinine had jumped from 1.3 to 1.8 and urea from 18 to 42. The electrolytes were normal. The RBS was normal. The lipid profile was essentially okay, but the serum albumin was on the hypoalbuminic range of around 3. LDH was marginally increased to 547, and he had a little bit of coagulopathy with a slight elevation of PT with INR. Next slide. The investigations for the fever panel that we were looking for to look for whether we are dealing with any infection-related glomerulonephritis were done in the form of malarial antigen, strep, leptospira, dengue, hepatitis B, HIV, HCV, which all came out to be negative. Similarly, we did certain other investigations like COVID RT-PCR because that presentation can have, the COVID can present in any way. We also did the patient's cultures, and we found that in urine culture, there was a growth of E. coli, which was more than 10⁵ colonies, which was sensitive to meropenem. This report we received on around 3rd day after the admission. So till now, what we have is that a young patient who presented to us with flank pain, hematuria, frothy urine, and fever. Later on investigations, we found a nephrotic range of proteinuria and mild hemolysis, which only on LDH we could find, hypoalbuminemia, hardly any dyslipidemia, TLC, which was raised. But no other fever panel was positive other than urine culture, which was definitely diagnostic that we were dealing with the E. coli infection, which was sensitive to meropenem. Next slide. We went ahead and did his imaging studies, and a USG abdomen revealed that the patient had bilateral enlarged kidneys with altered echogenicity and a loss of CMG. But there was no pelvic system fullness or a calculus. X-ray QUB, X-ray chest was normal. A renal artery Doppler suggested a high resistance waveform and an increased renal index in left renal artery, and a renal venous Doppler was normal. Next slide. So the only thing that was amongst our provisional diagnosis, if you recollect now, the first provisional diagnosis was acute pyelonephritis, followed by glomerulonephritis, which was rapidly progressive GN or an infection-related GN. So for the first diagnosis, which could have placed the diagnosis of flank pain, hematuria, fever, pyelonephritis, with the urine culture showing E. coli, but the nephrotic range of proteinuria was little difficult. And let me put it here into a perspective that a little bit of proteinuria, even in acute or chronic pyelonephritis, is very normal. Up to 1 gram, up to 24 hours is considered very normal in this, which reverts back to normal after the pyelonephritis disappears. But having found the nephrotic range of proteinuria, we were kind of concerned that why we are dealing with this nephrotic range of proteinuria. So we thought that are we dealing with any primary glomerular disease, which could be in the form of minimal change or a focal segmental disease, immune-mediated glomerular disease in the form of membranous nephropathy or lupus or autoimmune diseases, or inflammatory and infectious diseases, or a systemic cause for this nephrotic range proteinuria. So we started thinking and getting patient investigated on these lines. Next slide, please. So now again, with the same perspective that our patient had a history of fever, a rapidly progressive renal failure, which within 2 days jumped from 1.3, the creatinine, to 1.8, nephrotic range proteinuria, hematuria, and a deranged coagulation profile. Next slide, and next click, please. So we still kept a diagnosis of an infection-related glomerulonephritis, acute pyelonephritis, or a primary or immune-mediated glomerular disease. Next slide, please. And a renovascular disease, of course. So we started the patient initially on the day of admission, thinking about pyelonephritis and injection piperacillin tazobactam with linezolid. And after the blood culture reports were reported, we shifted the patient on meropenem, which was adjusted to the renal dose. The patient was given fluids, antiemetic, spasmodic, and vitamin K. And further, we planned the patient to go ahead to repeat CBC to look for any toxic granules or cystocytes, repeat renal functions and electrolytes, blood cultures, urine cultures, doing the immunological profile in the form of ANA, ANCA, and complement levels to look for any immune-mediated glomerulonephritis. We wanted to consider renal biopsy, but the patient had a deranged coagulopathy profile, and hence it was just considered but not planned immediately. We went ahead and did patients 2D echo, we planned 2D echo procalcinotin, and to rule out any other hypercoagulable states because one of our diagnoses was still a renovascular disease here. Next slide. But during the patient's course, the patient still continued to have fever, even after going from the broad spectrum to a narrow spectrum antibiotic, which the patient had shown sensitivity to. The renal function progressively deteriorated. Though patient was never having any problems in urine output, he was always non-oliguric. The left pain was persistent and the patient continued to have occasional vomitings. Next, please. So now over the course when the patient was with us, you can see from 7th to 14th, the patient's TLC count was almost similar. When he was admitted around 17,000. Until 14, the patient's counts were around 14,000 with similar DLC neutrophils of about 78 to 80%. The platelets, in fact, improved over the course, and the peripheral smear was always normocytic, normochromic. There were no cystocytes or any toxic granules seen. This CUE report was from the first day itself. Next slide. And now if you have a note at the renal profile of the patient, you see from the 7 to 15, the blood urea has jumped from 18 to 65 with a rapidly increasing serum creatinine from 1.3 to 4.7. Though the potassium was always maintained and sodium was always maintained, and the coagulopathy did not worsen further. So we now were dealing with a patient who had the TLC counts which were normal, but the renal functions were rapidly deteriorating and the other profile was almost stable and the patient still continued to have pain and fever. Next slide. So after the day 3 of meropenem, so this was after almost 5 days of hospital admission and about 2 weeks of patient's complaint before coming to our hospital, the fever spikes continued despite narrow spectrum antibiotics, a renal function which was progressively deteriorating, urine output which was maintained, left flank pain, and continued to have occasional vomitings. Next slide, please. So after this, with this picture of acute febrile illness, rapidly progressive renal failure, proteinuria, hematuria, and a diagnosis of an E. coli which would suggest an acute pyelonephritis, we were still struggling with the nephrotic range proteinuria. So our diagnosis was still infection-related glomerulonephritis and atypical hemolytic uremic syndrome because the renal profile was rapidly deteriorating. And then we started entertaining whether are we dealing with something which is non-infectious and causing all these symptoms, which could be in a young patient, a lymphoma. So the challenges in the diagnosis till almost the 6th day was an acute febrile illness, which was not responding. So we again thought that are we dealing with another fungal infection here? So we considered sending a fungal culture as well as a serum galactomannan. Next, please. Patient did not have any other predisposing conditions for pyelonephritis. So we were concerned here, though everything was pointing in direction of pyelonephritis, still the patient was not responding. And there were other associated conditions which we have been discussing. Next slide, please. So now that I had already discussed that though pyelonephritis causes proteinuria, it is never in nephrotic range of proteinuria. So again, with this and the patient's not responding, we were suspecting a glomerular disease or suspecting a renal vein thrombosis or any other hypercoagulable state, which was resulting in his fever, which could have been a non-infectious fever and a nephrotic range proteinuria. Next slide, please. So because we were not able to come to a diagnosis, we thought that it's time to take a opinion from our nephrology unit, and we referred the patient to nephrology unit with keeping in mind that are we dealing with an atypical HUS, infection-related glomerulonephritis, a lupus nephritis, or renal lymphoma, or a renal vein thrombosis. Next slide, please. In the nephrology unit, the patient still continued to have fever. The renal function further deteriorated and the patient developed metabolic acidosis and breathlessness and had to undergo 2 sessions of hemodialysis. The urine output was maintained again. The left plane was persistent and the patient developed bilateral crepitations. Next slide, please. A USG abdomen was repeated, which suggested that there was perinephric fat stranding and a pararenal facial thickening suggestive of acute pyelonephritis. But there was a query that then now there was a suggestion towards renal vein thrombosis, which was confirmed on venous Doppler saying that there was definitely a right renal vein thrombosis, but a left renal vein was not confirmed and it was a partial thrombosis. So we went ahead and did a non-contrast CT of the KUB of the patient since the patient had already renal impairment. And it showed that there was bilateral acute pyelonephritis, which was suggested by bulky kidneys and perinephric fat stranding. There was bilateral renal vein thrombosis, which was partial, but it was now extended up to intrahepatic IVC. And friends, this USG abdomen and KUB was done after 6 days of the first USG abdomen. And it also suggested that there was mild ascites in this case. Next slide, please. Also, the nephro team sent an investigation of PLA2R which came out to be less than 0.06. And this PLA2R is one of the investigations which are specific and sensitive for diagnosis of primary membranous nephropathy. So this came out to be negative. But having said that, PLA2R can be negative in 30% of patients of membranous nephropathy. In this, if you see that there, you can see the bulky kidneys and you can see the thrombosis in the renal veins. Next slide. Next slide, please. The renal team also went ahead to do a PET CT of the patient to look for any other evidence of malignancy anywhere. And what was found is that only that the bilateral kidneys were having a high uptake, which was suggestive of acute pyelonephritis of both the kidneys, left more than right. And you can see this here. And they had a suggestion of a right hilar lymph node, which was again taking a high uptake. Next slide, please. Now, the sequential investigations when the patient was with the nephro team, you can see that again, the patient's creatinine was rising, but the patient received a hemodialysis which decreased the creatinine here. And finally, around 28, the patient started receiving specific treatment, which I'll come to subsequently, when the creatinine and the renal parameters started improving. The CUE at, again, which was repeated, suggested that the 24 hours urine protein was high, but the urine culture came out to be negative. The LDH was again negative here, and the uric acid was on the higher side. The nephro team also went ahead and got a bone marrow done to rule out any evidence of lymphoma, and it was normal bone marrow. Next slide, please. A USG guided renal biopsy was done because though the patient had coagulopathy, which showed that the glomeruli were normal in size and cellularity with rigid GBM. The tubule showed vacuolations in tubular epithelial cells. The interstitium showed inflammatory infiltrate of compromising of neutrophils, lymphocytes causing tubular destruction. Vessels were unremarkable, and the immunofluorescence report, please next, suggested that there were fine deposits in the IgG type in the GBM with kappa and lambda type of deposits as well. With this, the entire renal biopsy report was suggestive of, next please, a membranous nephropathy with an acute tubulointerstitial nephritis. So membranous nephropathy was clinched by the renal biopsy here, though the PLA2R was negative, which can still be negative in primary membranous nephropathy up to 30% of the cases. Acute tubulointerstitial nephritis was again a diagnosis of biopsy here, because on CU we never found any indication which was suggested of any eosinophiluria or eosinophilia, which could have suggested any interstitial nephritis here. Next slide, please. So the final diagnosis of our patient was again that the patient came with acute febrile illness, which was suggestive of acute pyelonephritis on the ultrasound, on the PET scan, and a urine culture which was E. coli of 10⁵ sensitive to meropenem, but the patient did not respond to meropenem. But so a diagnosis of fungal infection still was kept. There was a rapidly deteriorating renal functions which required 2 sessions of hemodialysis. There was definitely an adult onset nephrotic syndrome, which was the complement levels were normal and the ANA was negative. We also had a bilateral renal vein thrombosis with IVC extension. And finally, a renal biopsy proven membranous nephropathy, which was PLA2R negative and with the acute tubulointerstitial nephritis. So we had a patient who we were dealing with a multiple complex renal diseases here. Next slide, please. Now, if we think about why our patient was having this, now in the retrospect, when we made a diagnosis of membranous nephropathy, we see that most of the nephrotic syndrome, because they filter out antithrombo-3, are predisposed to developing thromboembolic or venous thrombosis at different places. And membranous nephropathy has been seen to develop renal vein thrombosis almost in 17% of cases, more so in females as compared to males. Next slide, please. And when we talk about PLA2R antigen that I was speaking about 70% of patients of primary membranous nephropathy have PLA2R positive, which is highly specific and sensitive for this membranous nephropathy. But another 30% of primary membranous nephropathy can have PLA2R negative, which can be positive up to in 5% cases of THS domain 7A antigen or other antigens which can be seen in these cases. Next slide, please. So this slide again reinforces that 30% can be negative. And having said that, when the patient comes negative to be PLA2R, we have to do a workup for autoimmune patients, which can be for a mesangial deposits or a full house staining. It could be IgG pattern deposition, and one of the most rare causes of PLA2R membranous nephropathy could be the IgG4 disease. Next slide, please. So finally, when having arrived at the diagnosis, the management of the case, which was done after getting and subsequently doing this investigations, that the patient was treated with an antifungal after the PET-CT also suggested of pyelonephritis, and the patient was not responding to carbapenems. Patient received 2 sessions of hemodialysis. Because of a bilateral renal vein thrombosis, the patient was started on heparin initially, and afterwards was started on apixaban 2.5 milligram BD. And because we could clinch the diagnosis of membranous nephropathy on renal biopsy, the patient was started on the modified Ponticilli regime, which was when the patient received 3 doses of IV methylprednisolone, followed by cyclophosphamide and oral steroids. The patient also received ARBs to decrease the proteinuria in the form of telmisartan 40 milligram OD. Next slide, please. Now, the KIDCO guidelines actually differentiates membranous nephropathy into 4 categories: the low risk, moderate risk, high risk, and very high risk. They say that the patients who are low risk actually do not require any treatment. Our patient, if we see at the very high risk category, had a life-threatening nephrotic syndrome in the form of rapidly deteriorating kidney functions and also a bilateral renal vein thrombosis. So our patient was into very high risk category, and hence a modified Ponticillin regime was started for the patient. Next slide. So when the patients of membranous nephropathy after risk evaluation are done, in low risk, it is usually wait and watch. Moderate risk, if there are incidences that the patient can develop complications, are usually put on calcineurin inhibitors or rituximab. The high risk may be offered a choice of rituximab or cyclophosphamide, but in very high risk patients, cyclophosphamide is definitely advised. Next slide, please. So our patient received IV methylprednisolone on day 1, day 2, day 3, followed by oral steroid, that was Vicodin for 1, 3, and 5 months, and oral cyclophosphamide for 2, 4, and 6 months. Next slide, please. So after the discharge, the patient showed a very beautiful recovery. In fact, the patient visited me today and I happened to see him. He is absolutely does not have any edema, does not have any symptoms. The fever responded while he was in the hospital. And if you see that his counts though remained the same, his blood urea came up to 20 right after, a few days after discharge. Creatinine came back to normal, and a urine protein ratio came to up to 700, and a urine ACR up to 1.65. And on 1st November, if you see that the patient's urine protein of 24 hours is only 270 milligram per deciliter with a urine ACR of 1.37. And presently in this patient is in the cyclophosphamide phase of his modified Ponticilli regime. So our patient has showed tremendous improvement in his symptoms. Next slide, please. So what was the unique learning that we had with case? That we had to go back to basics. We were always hooked upon that the fever was infectious in nature, but this fever was infectious, it was inflammatory, and in certain times it could be due to malignancy also. The major finding here was a nephrotic range proteinuria. And though we have always been taught about the GAMS razor that, we have to give an hypothesis, which is the simplest hypothesis possible for our patient. At many a times, there are very multifaceted complex things in a patient that you have to take cognizance of each and every finding and the important investigation. So the nephrotic range proteinuria could not be just, ignored here. And that was the one which made us continuously evaluate the patient. There were multiple pathologies of the same system, which were were the complications of certain diseases, but there was a grouping of many multiple pathologies here, which made it very multifaceted and complex. And it is actually very difficult to say that what followed or preceded what. Next slide, please. Thank you. So this is our interesting case, and I am open to questions here.
Thank you so much, ma'am, for the wonderful case. Today, it would be very less to say that Dr. House would be losing his job. It was a very well managed case in the end. And in the end, in the young patients, whenever we are coming across these kind of patients, we always have to say because the whole life is ahead of them. So I would ask that in such kind of cases, what would be the prognosis of these patients?
Also, thank you, Dr. Deepak. The prognosis of membranous nephropathy in young males, if they respond to the treatment of cyclophosphamide, is actually very good. Yeah, but in certain cases, when they are cyclophosphamide resistant or relapse, then we have to go ahead with combination therapies, and the rituximab can be offered. Here also, actually, in the initial stages, since the patient is very young, rituximab was offered, but the patient was not affording. And the patient was very high risk, though cyclophosphamide was given to the patient. But the patient is showing tremendous recovery after it. And we are quite optimistic that though he's PLA2R negative and we do not have that levels to actually prognosticate him well, but still on the clinical findings and his improvement of the ACR, we are optimistic that the patient will have a good recovery at the end of 6 months.
Excellent presentation, ma'am. Ma'am, I would like to know that was this renal vein thrombosis due to membranous nephropathy or proteinuria was due to the right vein thrombosis?
Oh, yes. So thank you, Dr. Preeti, for this. And this question has been eating us up since the day one. Actually, when the patient presented with nephrotic range proteinuria, actually, initially we thought that it is just due to pyelonephritis. But this nephrotic range proteinuria could be a part of the presentation of renal vein thrombosis, which can be a complication of pyelonephritis leading to renal vein thrombosis and proteinuria. Or this renal vein thrombosis is a known complication of a membranous nephropathy, which again rapidly causes deterioration of renal function. So we finally wanted to accept the hypothesis that the renal vein thrombosis is a complication of the membranous nephropathy, which caused the patient to have rapid deterioration of the renal function. Though, like I said, it is very difficult to say that what led to what or what preceded what in this case.
Thank you, ma'am. So I would ask, since these kind of patients have a very long course, so is there any role of renal transplantation in these patients, or we have to wait because in these young patients they rarely progress to chronic kidney diseases. So end-stage renal disease is rare. So would we consider that he or she will land up in end-stage renal disease?
So yes, Dr. Deepak, that's a real good question because adult onset nephrotic syndrome has a little not as good prognosis as we would say for a minimal change disease, which is seen in children. And these patients tend to have a bad outcome. But membranous nephropathy, having said that, has better prognosis as if compared to FCHS or sclerosis, which we see. So what we are expecting that this membranous nephropathy, since it is responding now, if the patient does not have very frequent relapses, the patient may maintain and maintains for a longer time, the patient may not so early land up into end-stage renal disease. But having said that, we are dealing with a primary disease which is affecting the thing. So, and the patient is only 18 years old now. So we
That
really
is why,
don't
ma'am.
know after 8 to 10 years how the patient responds, how many relapses he has. And of course, if he goes into a stage of CKD, the patient would require other modes of renal replacement therapy.
Thank you, ma'am. Thank you for the so interesting case. Now moving on to our next speaker for the evening, Dr. Gurinder Pal Singh sir. He's professor and head in the Department of Psychiatry at AIIMS Bathinda. Sir has affiliation to Indian Medical Association, is a member and a fellow of Indian Psychiatric Society, is a fellow of Indian Psychiatric Society North Zone, International Association of Social Psychiatry, fellow of Indian Association of Child and Adolescent Mental Health, fellow of Punjab and Chandigarh branch of IPS, and fellow of Tri-City Psychiatric Society. Sir has many publications in national and international journals, accounting for a massive 19 number. He has recently won the GC Boral Award for the best paper presentation and the Best Paper Award in 2005 and 2010 respectively, and then again in 2022. Sir is not just in academics as a doctor, sir has also a very pleasant personality, and truly the topic mindfulness for pain relief will give us insight for treating patient not by the medications alone, but also by our intellectual abilities that we Indians are known for. So I would like Dr. Gurinder Pal Singh sir to continue with the next presentation. Thank you.
So my screen is visible?
Yes, sir, it's visible.
Yes, sir.
I'm grateful to Dr. Amit Gupta sir, Anuj sir, Preeti ma'am, Dr. Deepak, and Dr. Jain ma'am has made my work very simple. She was very beautifully explained. The topic is mindfulness-based intervention in pain management in clinical practice. I will just give you introduction. Then I will explain what is mindfulness versus mindlessness, which is cause of the pain. Then I briefly give you some clinical evidence, what are its benefits, and then conclude it. Everyone know that pain is a common experience. More than 56% of the US adults reports having at least some pain in the last 3 months. If you come to our AIIMS Bathinda, so many patients report about this pain. They go to the ortho department, medicine department, so many departments. 11% reporting daily pain and 30% reporting pain that has lasted at least 3 months. Another very problem is of chronic pain, backache, so many things. This chronic pain affects 1.5 billion people worldwide. There is a huge opioid epidemic and rise in opioid misuse, particularly in North region and particularly in Punjab also. This chronic pain can impair cognition, increase risk for anxiety, depression, and other affective disorders. This pain has also been linked to increased healthcare utilization and reduced occupational activity. As this is just the brief definition of mindfulness, I'm going to say what is the importance of the present moment. Yesterday is a history, tomorrow is a mystery, today is gift known as present moment. So this definition has been given by very famous scientist Kabat-Zinn, is stable, steady, calm, alert, observant, clear, deliberate, purposeful, active, focused, engaged, and yet detached, skillful awareness of the present moment. Historically, the focus of therapy has been to cope up with or cover up the pain. So we give medication, so many medications are available. Now a new approach to this problem is there, acceptance without judgment or resistance. So this basically mindfulness means being fully aware of where you are, what you are doing, who you are with. For example, I am giving this lecture, so I should be fully aware of 100% focused on this. And another is being fully aware also your body, your thoughts, feelings, mind, and its content, and your surroundings. We have made our way very complex. So in this, we move from the level of conceptual thinking to the level of direct, non-judgmental awareness. So basically, the state of attentiveness towards experiences that is characterized by curiosity, openness, and acceptance. So these arising thoughts, sensation, and feeling are always subject to observation. They are noticed and accepted without even evaluation or judgment. Basically, the concept of mindfulness is attention without attention. So this is, if you understand it, you will understand what is mindfulness, what happens in the pain conditions. So many clinical conditions, what happens to the patient, the pain. Basically, there are two types. One is focus attention. In this, the client is taught to sustain attention on an automatic and dynamic stimulus like having breath sensation. So breathing exercises are given in that. Another is open monitoring of the observation. So basically, aim is at gaining mental control and stabilization of attention. Basically, we increase the level of awareness. So there is awareness that is known as meta-awareness of arising sensory, affective, and cognitive events. Like this, we just watch your thoughts, feeling, and memories flow like the wave of oxygen against the seashore. They do come in and they do go out. The most important principle of mindfulness that everything is not permanent. So we have an impermanence. I'm giving this lecture, after half an hour, this time will go on. So this concept is very, very interesting. Basically, the aim of mindfulness is not to eliminate all thought. Thinking is not the problem. Realize that your thoughts, feeling, and memories are not you. So we have to live in the mind's natural state, mindfulness, boundless, spaceless, being that means presence of mind with detachment and without judgment, condemnation, or evaluation, without trying to control, without resistance, suppression, or sublimation. So basically, this process is active, not passive, is experiential, not intellectual. It comes with the particular practice only. Now, another phenomena is mindlessness, which is the mother of all forms of the pain. If you go to any roads, you see how the vehicles are going on. So this, like when a person is having pain, for example, there is a trauma, you just go this and see on the roadside how the people are doing. So the people are damaging more because they do not know how to handle the trauma cases. So this mindlessness of our attitude is the form of all problem. In this mindlessness, this is the other polar of mindfulness. One side is mindfulness, fully attention without tension. In this mindlessness, there is hypersensitivity of pain. There is lack of awareness about the current moment, current action, preoccupation with thought and feeling about the past or the future. So this mindlessness is the basically endless non-purpose thinking, especially a negative time, is the problem in this cause of the pain. If you see the various tracts, spinothalamic tract, and the ascending and descending, so transmission of the pain from the A delta fibers and C5 of first order neurons to second order neurons in the spinal cord, and then motor neuron stimulation, thalamic transmission, cortical perception of pain, reticular formation. So this mindfulness concept, in particular at the thalamic transmission, I will explain in detail how it occurs. Now, a question arises, why this mindfulness has been found to be effective for pain? Pain has highly distributed network of brain mechanism, as I explained it. So in mindfulness, there is a cognitive control, emotional regulation, acceptance, and improved mood. So basically, there are two types of pain, physical pain and mental pain. Physical pain, for example, there is a trauma. There is a physical pain. So this is the first arrow. First, there is a noxious sensation. This is followed by the mental pain. Second arrow, worry, distress, pain evokes suffering. So this combined physical and mental pain, they create so many issues. So when a person is mindfully trained, he will not cling to various sensory pleasure. He will less engagement of cognitive and effective appraisal of the pain. So if you understand, basically mindfulness work on particular brain region, orbitofrontal and anterior cingulate cortex. They are associated with the self-control. So basically, it acts on the thalamus. This brain region serves as a gateway that determines if sensory information is allowed to reach higher brain centers or not. So basically, brain circuit, they are same for the emotional pain and physical pain. So if you understand the basic concept of this pain etiology and how mindfulness works, that basically deactivate the thalamus region, deactivate the message from the low center to high center, and this deactivation helps in relieving the pain. So there is a disengagement from pain-related threat, extinction of the fear conditioning, acceptance-based coping strategies, strengthening the ability to self-regulate effective appraisal of nociceptive input. Basically, we have to understand that mindfulness is not just relaxation. It is not just stress relief, but it does involve identifying and recognizing pain-causing factor. So if you understand it, if you alleviate it, only then the pain reduction can occur. So many clinical evidence has been there. So it reduces stress and subsequent increasing attention, increases self-compassion, increases clarity of thought and capacity for reflection, experiences of a greater capacity for empathy. This work started by John Kabat-Zinn. This is a pioneering work. They developed mindfulness-based stress reduction program. It was 8-week intervention during which patient meet weekly for 2.5 hours The participants are introduced to the practice of mindfulness with body scan, sitting exercises. Participants learn to be more responsive and less reactive in the face of challenging stressful situation. Basically, there is a stimulus followed by response. If you increase the pause between the stimulus and the response, you can understand the mindfulness. So this pause is very, very important. How we react to the situation, how we react to the painful condition. Another meta-analysis by Grossman et al. In 2004, they have given very good evidence because they enhanced ability of coping with distress, improvement in quality of life, patients suffering from pain, cancer, and depression. Another study by Carmody and Weir, the psychological well-being increased, perceived stress level decreased, illness-related stress, chronic pain, other stress, evidence was seen in these particular conditions. This is again a very interesting meta-analysis. Brief mindfulness-based intervention for acute and chronic pain is systematic review. 20 studies meeting eligibility criteria were identified. Of the 25s, they actually across the 20 study, 13 were delivered with audio-video recording only, and 12 were delivered by a provider. Participant-provider contact ranged from 3 to 80 minutes. And this delivered in a particular format by a provider and lasting more than just 5 minutes showed some promise in the management of acute pain. So many RCTs, pilot study program has been done in this area, and they are particular for the pain relief, stress-related disorder, binge eating disorder, post-traumatic stress disorder. This dialectic behavior therapy is also a very interesting therapy. We particularly do in borderline personality disorder who are more prone to deliberate self-harm and causing so many pain issues. Another very interesting therapy is acceptance and commitment therapy. And this therapy results in a decrease in pain, and pain relief can be reported after developing mindfulness skill. If you just see the psychotherapy, there are 3 waves of psychotherapy. First wave came, then second wave came. These are all the third wave recent psychotherapies, and these are very effective, useful in the pain conditions. So there was a particular program for pain relief. This was developed by a very famous Kabat-Zinn and others. Mindfulness-based intervention improve pain symptomatology across a wide spectrum of pain-related disorders like fibromyalgia, migraine, chronic pelvic pain, irritable bowel syndrome. It was an 8-week mindfulness-based stress reduction program, which was studied and validated across approaches for the treatment of chronic low back pain. In this seminal study, the authors revealed that chronic pain patient reported very significant improvement after, and their quality of life also improved. And another was this improvement was sustained after a 3-year follow-up, and this was a very important study in this area. Another study was done among various groups. So because in mindfulness, this trial is very, very difficult. So they made some certain groups. 75 healthy pain-free participants were randomly assigned to one of the 4 groups, mindfulness group versus placebo analgesic cream or control. The mindfulness intervention group reported that pain intensity was reduced by 27% and the emotional response to pain was reduced by 40%. In contrast, the placebo cream reduced the intensity of pain by just 11% and the emotional aspect of pain by 13%. This is again a very interesting study because in the mindfulness, so many fMRI studies have been done. And they have found that there are certain traits in the personality of the individual. It could be brief mindfulness training and it could be extensive mindfulness training. And there was significant change in particular region of the brain, right? Precuneus, prefrontal cortex, and so many areas. And this has been very, very much elucidated. This study is very interesting. Positive well-being and usefulness of brief mindfulness-based intervention for pain in the cancer. This was conducted by us and other group of the people. And this is recently published just in this month ago. Very interesting. We took 40 patients of cancer and the result was very good. And the pain severity, pain interference, pain catastrophizing, and managing psychological aspect of pain perception. And this was very, very elucidated. In another case, we had admitted one person who was a migraine patient, and it was not relieved. A patient was given this type of therapy, mindfulness-based cognitive behavior therapy for 8 weeks. During the 8-weekly session, first week, the mental state of autopilot and mindfulness, first-hand experience of mindfulness, where exercise is explained. Similarly, in second week, the person was explained between relationship between thoughts and emotions, awareness of pleasurement, mindfulness practice, sitting meditation. In third week, again, this 3-minute breathing space, awareness, the unpleasant event, 4 week. So in this 8 week, the results were very, very good. And we have developed a special clinic on Friday, and we have got 120 patients of migraine and other pain relieving, and they are going very good results. So basically, there is a before and after significant changes in the brain, also neural changes. So that has improved, given us a lot of evidence in this area. But I'm saying that still a lot of work has to be done. Fortunately and unfortunately, we are much lagging behind in this area. If you go to USA, 70% of the school students, they are given the lectures on mindfulness, how to handle this, how to this. Basically, it is a skill, how to handle the pain conditions, particularly suffering, how to do stress management. So these challenges remain on the efficacy front, because I am already saying that doing study in this is very, very tough. How many tools are there, how many skills are there, still it is a more research is required. This many people meditate to reduce psychological stress, and stress related health problem. So particularly in this, we found not much evidence that were better than active treatment for the drugs, exercise, and other behavioral problems. So results are equivocal. If you compare, it is more just like an adjuvant or add-on therapy. Results are very, very good. So what happens is when there is a non-mindful reaction to any painful distress. So what happens? He either avoids it or suppress feelings. So distraction is there, negative thinking or rumination there. So this vicious cycle of pain increases that pain. When person has a mindful response, what happens? He's allow accept whatever arises. So there is a non-judging and there is a letting be. So whatever that acceptance or that pain relieving is there with mindfulness response. So there are certain benefits of the mindfulness. It changes in the brain fluid, increased cortical thickness in the gray matter of the brain, a calmer, more patient, stable, and steady mind, overall relaxation of the mind and feeling of well-being, improved ability to cope with and release pain. So there is an enhanced cognitive functioning and performance. Basically, just as we do physical exercise good for the body and can make positive changes to the body, so this mindfulness can make positive neuro, physio, psychological changes to the mind that can lead to reduction in the pain, feeling, and its other attachments. So mindfulness is medicine for the mind, which deals effectively with the negative thoughts and emotions, very, very severe pain, feelings, suffering, and stress, and thus disease. So this is eased by this technique. Now coming to the conclusion. Mindfulness is relevant to affect pain management. It can be integrated into standard treatment for pain-related clinical conditions, particularly migraine patient is very useful. We are using it. Adjuvant or add-on. I'm still saying that it's a just add-on. Another, not to be compared with other opiates or other like that. Its benefit depend upon continual practice. Mindfulness is a two-way channel. Both the client and the interviewer, they should be mindful. So it is not a single session. I'm just giving you a lecture. You say there is mindfulness skill. That is not okay. It requires a continued practice. And this area requires more research because our country is very poor. We cannot afford this opioid epidemic, opioid misuse. So many things are there. If this is used in general practice, routine activities, mindfulness eating, walking, dressing, so many things, mindfulness talking. So this is very, very useful for our poor country. With these words, I thank the organizer. Thank you very much.
Thank you so much, sir. It was a very enlightening talk. So, as we all know, health is not just about physical well-being of a patient. It also states toward the mental and the social well-being also. As clearly said by you, so in your general practice, so as we physicians come across to many such patients in the OPD also. So what would be like you that we give the advice to the patients for a short while even that would be helpful to the patients?
We just give them mindfulness breathing technique. We just ask them focused on your breath and just inhale for a few seconds, then just pause, then exhale. This is known as mindfulness breathing technique. It is wonderful. Just 5 to 10 minutes daily of that exercise very. Another type, mindfulness walking, how you are walking. So that is very, very important. Just on this trip and this just slightly walk. We have to enjoy the nature. We are going away from the nature. So these brief techniques, they are very effective. Their patients are very also have great happiness. They are very, who do regularly, they have very good results.
So what is the duration of this mindfulness intervention?
Basically, if you see the protocol, whatever the manual, they say 20 minutes per day is very, very important. If you do 20 minutes, 5-day week is very effective. So basically, there is an 8-week course. Generally standardized 8-week course, but we have I'll explain that brief mindfulness training. 20 minutes per day, 5-day week is very, very good, particularly in the pain condition and the recurrent depressive disorder. There are so many nice guidelines. They are in recurrent depressive disorder. As I explained, there is a first pain, physical pain, followed by emotional pain. Emotional pain is more harmful than the physical pain. So this emotional pain is relieved, then physical pain is also relieved.
And so, since mindfulness is such a great thing, so can we implement this idea in patients of anxiety and those who are having depression?
Yeah, definitely. Not in anxiety, it is only useful in recurrent depression. You try to understand that first depression episode is there. If you use it, it will harm it. So there is a second or third episode because it is a brain mechanism. If you do in first episode, it is harm. In the literature, it is when the person has third episode of depression, it is effective. That is not recurrent depressive disorder. It is more useful in recurrent depressive disorder because there is a rumination going on. First episode, we should not use it. Only third episode, we should use it.
Thank you, sir. Thank you for such a wonderful presentation. I would now request Dr. Amit Gupta, sir, to speak a few words and propose vote of thanks.
Thank you, Dr. Preeti. On the behalf of American College of Physicians India chapter, I would like to thank Dr. Vishakha, Dr. Deepak, as well as Dr. Gurvinder Pal Singh for their very eloquent presentation on different topics. And I'm sure the ACP India chapter members, they must have found it very, very useful. There is one important announcement which I would like to make here, and it is as guided by the governor of ACP India chapter, Dr. Anuj Maheshwari. From January onwards, the ACP India chapter will be giving certificates for those who will be attending ACP India chapter case files. And these certificates will be awarded at the end of the year, provided the attendees, they have attended more than 75% of the case series which is presented. So those who will be attending more than 75% of the episodes of ACP India case files, they will be awarded with a certificate of appreciation by the ACP India chapter and by the governor of ACP India chapter. So this is one important announcement which I wanted to make today. And once again, thank you all the respective faculties, and thank you, Dr. Preeti, for setting this up and carrying the ACP India case files regularly on your shoulder. Thank you very much.
Thank you, sir. Thank you so much. I would like to thank both the speakers and our moderator for such wonderful presentation. And I believe many good experiences have been shared, and I'm sure that the take-home message, they will deepen our thinking and our knowledge. So thank you, everyone, and goodbye till next ACP case files.
Thank you. Thank you.